This is Jerry Hesch with the Hesch Institute, presenting a very interesting case of downslip ilium in a client with hypermobility syndrome. Happens to be a male, 40 years old, with distinct hypermobility throughout his body, throughout his joints. Surprising the degree of hypermobility that he has. Yesterday we treated him for a sacral torsion, and we were able to reduce that pattern, but he continues to feel like he has an asymmetry of the sacrum. When he sits, he feels like he's sitting a little bit asymmetrical. It's not due to his hip position. We checked his trochanters, top and bottom, front and back. We checked the length of the femurs in sitting and supine. Same for the tibia, same for the pelvis. Now, we did find a downslip today, but that can be very subtle. So visually we can miss the downslip, yet he perceives it. This is someone who was a very competitive athlete in tennis and gymnastics, etc. In spite of his hypermobility, he was very strong and very active. And so he has a very good sense of his body. And he points right to the sacrum, the lower quadrant here, and the torsion that he had, this was prominent and stuck yesterday. It's not today, but when he does come up in a sphinx position, he feels like the sacrum twists, and it actually does, but it's only a muscular and ligamentous phenomenon because it springs. There is mobility in the joint. So I'm going to demonstrate that right now. So here is his pelvis, and when he is lying in prone neutral, and I palpate the lower sacrum, here's the ILAs, so coccyx is here, we're at S4, he is symmetrical. Could you get up on your elbows, please? So when he comes up in this position, this is where he feels the asymmetry, and this thumb does in fact move up towards the ceiling by about 1/4 of an inch. However, I can load it and take the slack out of the system, and I can then spring it. Okay, the same phenomenon is observed when he's up in child pose. Could you get up in child pose, please? And of course, we're not going to be able to see it on the camera, but I'll just talk you through it. So in this position, we have to again isolate the sacrum. You can see a microdiscectomy scar there. This is top of the ilia, and you can follow the ilia down, and you can almost see the PSIS is right here. So you wiggle around the PSIS so that you get to the very top of them, okay? And when you're at the very top of them, there is a peak in most clients, and you can even get underneath that shelf there. But as you walk across, you're at S2. So you come up one thumb width, and that is S1. He's symmetrical looking, but again, it's not a matter of how it looks. It's more about how it functions. And if we come down to S2, we come down lower, and now we're at about S4. And yes, this left thumb does stick posteriorly, okay? However, I can load it, and I can spring it. So the mobility, the force goes through that, it translates through it, so that does not qualify as a sacral torsion because it's not stuck. The reason it behaves like a torsion is because he has a downslip. Would you lie on your stomach again, please? And filming here at the Hesch Institute is not the most ideal thing. We're a small organization. We need a proper film crew, proper models, and proper lighting, and all of that good stuff, which someday we hope we'll have. If you have an extra one lying around, you can donate it to us. But for today, I'm the camera operator and the clinician, and him being the patient, he's not much help other than have an interesting case. All right, that's the humor there. So PSISs are somewhere around here, right there, and I'm on the PSISs, and so if I come just below that, I palpate the long dorsal sacroiliac ligament. If I walk across this one, I isolate it, and then I indent it. It's very firm, okay? On this side, it's harder to isolate, and when I indent it, it springs much more readily. So because the ilium is down and the sacrum is stable, he is mechanically shortening that ligament, and therefore it should be softer. On the other hand, the sacrotuberous ligament that goes from approximately the ILA to the medial part of the ischial tuberosity that gets lengthened because the hemipelvis shifts down and the sacrum stays put. So the sacrotuberous gets lengthened. And so you can find the ILAs and you can find the bottom of the gluteals, the crease. You can make a little triangle there, and the index finger represents the sacrotuberous. Sacrotuberous ligament is right here, except that it feels like a bone. I'm putting a lot of force in here, and I cannot indent it. It feels like bone, and there is no bone there anatomically. If I come over here, this is his right sacrotuberous, and I can indent it, and I can even spring it just a little bit, so it yields like a ligament should. Then if we come back to the ILAs, sacrospinous is at a slight angle here, accessible right here as you fall off the sacrotuberous, and there it is right there. I can indent it slightly, and I can spring it, but it's a very stout ligament, so we get very small yield, very small movement, and that's normal. Okay? Again, sacrotuberous is here, so if we fall off sacrotuberous right in here, we should be able to isolate right there. There it is. The sacrospinous, I cannot indent that at all. It's very, very hard because he has a downslip pattern. Now, the only way to, that's kind of conformational information on the ligament, but the true test is the spring test. So we scoop underneath the ischial tuberosity here, and then we take up the slack to where the body stops moving. Now most of our force is going to translate through the SI joint. I said most. There's a spring, and you can see it move, and you can see it recoil. And if you were to look at his head, you would see that movement happens all the way through his body. On the left side, I'm trying to take up the slack, but I can't. There's absolutely no movement. I'm doubling the amount of force, and I can't take up the slack. It's absolutely stuck. So push as I may, I cannot get any movement. Okay? Now, I'm going to correct it. I'm going to mobilize that up. It's going to take me, I'm going to see if I can do it in a minute, but I will actually spend 5 minutes doing a longer correction. It's the preferred technique. But anyway, we're going to keep filming without stopping the film, and you get to watch that sacrum while I do the treatment to him. Would you lie on your back, please? Unfortunately, I don't show the treatment techniques because it opens me up in the medical legal realm. Makes the Institute vulnerable, and it's really unfortunate, but that is what it is, and we're just not able to. So are you okay with this force?
Yeah, you know, there's a little bit of the internal rotation.
Okay.
Capsule.
So let me modify that. Is this okay here?
Yeah.
Okay. So I'm just going to do a very brief downslip mobilization, but I'll come back and do a longer version afterwards, and I will teach you how to keep the correction.
Yeah.
We developed a vertical SI support which you may benefit from, so we can lend it to you, and if you find it helpful you can purchase it, otherwise you can return it. And we're the only ones that make a vertical SI support, and yet many ligaments have a vertical orientation, or at least one of the vectors is vertical. So let's have you lie on your stomach, please, and let's see if we made a difference. And we will teach you how to self-treat the downslip,
Okay.
just as we did with the torsion. And that's what we believe. We believe in making people independent.
Sounds good.
Strange business philosophy, I guess. I know. Painful business philosophy. Okay, you laugh when you can't cry. All right, so we take up the slack, and I can take up the slack now. Spring, 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 and you see a recoil. And if I did it properly, when I let go of the take up the slack position, there'll be a final recoil right now. There it is. And so I would predict that if that succeeded, then this ligament should be softer. I can indent that ligament. Sacrospinous is going to be right here. I can indent him. And comparing the tone in the long dorsal SI ligament, remember the right was the one that was somewhat taut, and the left was loose, and I find them to be fairly comparable. Could you sit up and just tell us how you feel in sitting? So the concern, of course, is that he has hypermobility syndrome, and we need to discern if he has greater laxity or if that was just a positional dysfunction that will stay corrected. So we'll be able to make that discernment. But the fact that he has hypermobility does not mean that he absolutely has instability of his SI joint. It could be just a positional and reflex instability that's readily corrected. How do you feel in sitting?
You know, I'm assessing it out here. It takes some time for that sort of asymmetry to really sort of sink in and feel
Yes.
as if it's,
Yeah.
I told you I was resting more, I felt like I was always resting more on the left side of my coccyx and whatnot.
Uh-huh. Yes? So it's hard to tell, right?
It's a little difficult to tell. I mean,
Okay.
it would take some time, I think, to just kind of sit here and hold this
Okay.
position for a while. But maybe I can get on my stomach and do the cobra. And,
Do that, please.
and see
Go
if,
ahead.
that
Yeah, go
gives me
ahead and do that.
That one sense.
Go ahead and do that. And I'm just showing off my bulletin board. That's a book chapter I wrote. And then over here I was trying to zero in on some research on the Hesch method. And anyway, go ahead and get up in cobra position and let us know your thoughts. And I'm going to put my fingers on that lower sacrum and see if I perceive a difference. So go ahead and get up there in good, in full extension. Stay there. Lower sacrum is right here. Symmetrical. How do you feel?
Well, I feel, honestly, there still feels a little deviation.
Okay, so stay there. Stay there. So I'm going to look and see if there's a side bending deviation. I can't perceive it because I can move you in side bending. I don't perceive it, manually. And then if I come on to the upper sacrum, I don't perceive it there either. If I come on the PSISs, I don't see it there. So it's going to take a little bit more detective work on my part. Come up again, please. There's a little hint. It's subtle, but I think the right PSIS in that position becomes a little bit more prominent. So we obviously, have more detective work to do to try to find out what's going on that makes you perceive it. Does it feel exactly the same, or is there a slight change?
No, it might feel a little bit better. I mean, one thing I was thinking is that I wonder if it has anything to do with not the sacrum, but L5.
Could be. Could
after
be.
the surgery.
Yeah, could be. Could you?
Yeah.
Yeah, could you come up in child pose, please, and let's see how it presents in that position, and then we'll stop filming. I meant to make this a short film, and we're at 12.5 minutes. Terrible. That's the Hesch method, taking a long time. Okay, so in this position, you still present with it looking like a torsion. So for some reason, there is in fact an asymmetry that happens in the lumbopelvic region. And right now, at this moment, I cannot discern why. Okay, so I'm going to go ahead and stop filming. Okay. This was an example of treating a downslip in someone with hypermobility syndrome and how it gave the appearance of a torsion, but it in fact was not a true torsion. And as often happens, you correct one thing and then it undergoes a little bit of change. That's one of the secrets about the pelvis, the lumbopelvic / as they call it, the SI joint region does undergo change when you start treating it. So you have to follow the change and keep moving forward. You don't just make a single diagnosis and assume a single treatment. That's it for now. We're at 13.5 minutes. I will stop. Thank you very much.